Okay, my name is Heun. I'm a consultant psychiatrist and I'm professor of psychiatry and I'm the chairman of the Global Psychiatric Association. And today we want to introduce the conference on war, trauma, and mental health. Sadly, this is an important issue, and I would like to introduce the chair of this meeting, who is currently traveling, and I hope that he can be seen and show his face. It's president. He's president of the Indian Psychiatric Society, Professor Rao. He's professor emeritus of psychiatry and chief coordinator of psychosexual medicine. He's past president or past general secretary of the Indian Psychiatric Society. He's editor of journal Psychosexual Health, and he's president of South Asian Societies for Sexual Medicine. And he has published more than 380 articles, books, and book chapters, and I hope he's available. And if he's not available, then Professor Sujit Kar, who is the chairman of the Global Psychiatric Association, will take over for him. So, Professor Rao, are you available?
Uh, Professor Rao is not available right
Okay.
now on Zoom. So, good morning or good afternoon or good evening, wherever you are. So, friends, today we'll be having a symposium, War in Mental Health. We'll be having four speakers. We'll be talking about different aspects of war and their impact on mental health. So, it's a proud privilege to invite our first speaker, Dr. Vipul Janardan, who is a consultant psychiatrist and right now he is having 12 years of clinical experience in mental health care and is active member of World Psychiatric Association fellow, and he's active member of Global Psychiatric Association. He is having some important roles of some subcommittees of Indian Psychiatric Society, and he also published a book on understanding sexual dysfunction, a psychiatrist guide, along with Professor T.S.S. Rao. So with this introduction, I request Dr. Vipul Janardan to start his presentation. Over to you, Dr. Vipul.
Thank you so much for this generous introduction. So, without wasting time, in this era of war, I'm warmly welcome you and thanking you for taking out some time and bearing me here. And moreover, this is also a season of football, so everybody will be busy. So, still, without wasting time, thank you for Global Psychiatry Association, Dr. Rainer, for giving me opportunity to speak on this important and timely topic. When we think about war, we often focus on the visible consequences: loss of life, physical injuries, displacement, destruction of the infrastructure. However, some of the most profound consequences are invisible. The psychological wound caused by war can persist long even after the gun falls silent and the physical reconstruction begin. Across the world, millions of people are currently living in the conflict affected region. We can't say across the globe that we are not in the time of war. Whether we are in the war or in the proxy war, or we are indirectly affected by the war. So we all the across the globe we are in the war zone. Having been displaced by war, these individuals face enormous psychological challenges, including trauma, grief, anxiety, and enormous psychological distress. As a mental health professional, million of people is affected. So it is our responsibility not only to to understand the consequences, but also to develop active intervention that promote healing, resilience, and recovery. In this presentation, I will be discussing the psychological impact of war, the neurobiology of trauma, vulnerable population such as children, women, and evidence-based intervention that can help address mental health of the conflict-affected population. Ultimately, the goal is to understand how we can transform trauma-informed care into a meaningful action that support those affected by the conflict. So learning objective of this, understand the psychological impact of war, recognizing common psychiatric disorders, identify vulnerable population, and evidence-based intervention. Before discussing the psychiatric consequences of the war, it is important to appreciate the scale. According to the recent UNSCR estimate, more than 123 million people worldwide has been forcibly displaced due to conflict, violence, and persecution. This represents one of the largest displacement crises in the modern history. Importantly, nearly 40% of refugees are children, making them particularly vulnerable to the psychological effect of the trauma, disruption, and loss. These numbers remind us that the war is not geopolitical level issue, but also a major global mental health challenges affecting millions of people. So in this paper, they say there is nearly 180 million people were displaced by the conflict and persecution. So whatever the number, whether it is 123 or 118, the number is huge. Behind these statistics are real individuals and families whose psychological suffering often continues long after the physical safety is restored. So what is the psychological impact of war? So this is a vicious cycle. It starts from the chronic uncertainty and fear. It starts from the exposure to violence and death. There is loss of the loved ones, and there is displacement and migration. And then further, there is a breakdown of the social structures. Then again, chronic uncertainty and fear. And then again, this in a one way or directly or indirectly turn into the violence and death. And again, the war. So war affect mental health through multiple ways. Individuals are often exposed to violence, death, and life-threatening situation, which one can overwhelm normal coping mechanisms.
Sorry, I'm in a lecture.
Many experience that
I'm
the
just
loss of the
explaining
loved
why
one,
I'm so
homes, and the
it.
communities, leading to the profound grief and the emotional distress. Displacements and the forced migration further increases the stress by disrupting social support system and the certain uncertainty about the future. At the same time, war often results in the breakdown of the social structure, including healthcare, education, and community network. Together, these factors create chronic fear and uncertainty, significantly increase the risk of PTSD, depression, anxiety disorders, and other. So, what are the common mental health disorders? We all know PTSD, depression, anxiety, substance use disorder, complex trauma and grief. And long term, there is change in the personality, substance misuse, suicide risk. These are all things. In the one of the recent, when I was preparing this slide, I've said this one of the recent analysis in the Lancet, it was published. There's 24% of people in conflict settings have a mental disorder, with about 9% experience moderate to severe condition. So this is a huge number. we can estimate the gravity of what war can do. So PTSD in the conflict setting, this is the signature disorder that happens after any war. A lot of people suffer from this. So it is characterized by intrusive memories and nightmares, hypervigilance, avoidance behavior, emotional numbing, and functional impairment. Children and adolescents are most vulnerable victims of armed conflicts. Exposure to war can disrupt critical stages of emotional, social, and cognitive development. Separation from parents or caregivers or may impair attachments and create feeling of insecurity and abandonment. Conflict often interrupts education. It deprives children of stability, routine, care, and opportunity for growth. Many children develop behavioral problems, including aggression, withdrawal, emotional dysregulation, and difficulty in concentration. Importantly, adverse experience during childhood can have a long lasting effect. It can stay with them till their life, increasing the risk of mental disorders, also like PTSD, depression, substance use, and other form of psychopathological later in life. So early identification and intervention are therefore crucial to promoting resilience and healthy development. Women and vulnerable population often face unique mental health challenges during the war and armed conflicts. Gender-based violence, including physical, emotional, and sexual abuse, frequently increase during the period of the war and displacement. Survivors of sexual trauma are significantly higher risk of developing PTSD, depression, anxiety, and complex trauma-related disorder. Pregnancy and motherhood during conflict bring additional challenges, including the limited access to the healthcare, increased stress, and concern for the safety of the both mother and the child. Woman also assumes difficulty in caregiving, responsibility for children, and injured family member, adding to the emotional burden. Furthermore, social exclusion, stigma, and the economic hardship can compound psychological distress and hardship and hinder access to support and treatment. Refugee and an internally displaced person. Refugee and internally displaced person face conflict, both internal and external, have multiple stressors that extends far beyond the initial trauma of war. Many experience acculturation and stress that adapt to a new language, culture, social environment, uncertainty about the legal status, economically weak, and no monetary gain. So these are the things that happens, and poverty and the unemployment further contribute to the psychosocial distress, while isolation and separation from the family members can worsen feelings of loneliness and helplessness. Access to the healthcare, including the mental health services, is frequently limited by financial, linguistic, and the administrative barriers. During my residency training in Delhi, working in hospital, so I had witnessed and had opportunity to interact with several Afghan refugees. Many had fled conflict and experienced significant losses. Despite reaching a place of relative safety, they continue to struggle with anxiety, trauma, memories, uncertainty about the future. And despite the adapting to the new environment, their experience reinforced for me, though the psychological impact of war often continues long after people leave the conflict zone, and even the medicine and the pharmacological measures does not work well as to the other patients. So neurobiology of trauma, I don't want to go in the detail of that, because we all know HP axis dysregulation and amygdala hyperactivity. There is hippocampal changes, and there is altered stress responses, and on the top of it, there is an epigenetic influence. In PTSD, the amygdala become overactive, the hippocampal shrinks, and the prefrontal cortex loses some of its regulatory control, leaving the brain stuck in the survival mode. So effective, this is slide of assessment in the conflict zone. So effective assessment in conflict zone requires more than the symptoms identification. It requires understanding the person's trauma, culture sensitivity, and safety and the community context. Assessment in conflict setting requires a trauma-informed and culturally sensitive approach. Many individuals have experienced severe adversity, and it is important to create a safe, non-judgmental, neutral environment that promote trust and disclosure. Cultural sensitivity is essential because the expression of the psychological distress varies across the different communities and culture. A comprehensive assessment should include evaluation of the trauma exposure, providing the safe space, current symptoms, functioning in the social support, and immediately safety concern, including the risk of the self-harm, suicide, or ongoing violence. And standard screening tool like PCL5 for PTSD or PHQ for depression, and GAD7 and other tools can be helpful. They should be complemented with the interviews and other things, not replaced with the clinical judgment. Community engagement is equally important. Working with community leaders, local healthcare workers, teachers, and families help improve of mental health needs, reduce stigma, and facilities access to the. In conflict settings, assessment not only about the diagnostic illness, it is also about the understanding of the individual need, social and cultural and the environmental context. So management of trauma-related mental health problems requires evidence-based intervention. Psychological first aid is often the first step, focusing on the safety, support, and the stabilization. Trauma-focused cognitive behavioral therapy helps individual process traumatic experience and develop healthier coping mechanisms and strategies. EMDR, eye movement desensitization or destabilization and reprocessing, is an effective treatment for PTSD by facilitating adaptive processing of traumatic memories. Narrative expressive therapy is particularly useful for refugees and the survivor of multiple traumatic events. Pharmacotherapy, especially SSRIs, may be useful when the symptoms are severe or when comorbid with depression and the anxiety are at present. When individual treatment is important, sustained recovery is conflict setting requires community-based approaches. Strengthening resilience, help individuals and the community adapt and recover from the adversity. Peer support system provide emotional support, resilience, and reduce isolation and foster a sense of bonding and also the belonging. School-based programs are particularly important, and it helped to increase awareness, reduce stigma, and access to the services. Finally, capacity building through training of the local healthcare workers, teachers, and the community leaders, ensure that the mental health support remain available in resource-limited setting. These approaches help create resilient community capable of the supporting long-term recovery. Healing after war is not just an individual process. It is a community process that requires resilience, social support, and local capacity building. Coming to my next slide, role of a psychiatrist, or better say mental health professionals. Psychiatrist or any mental health professional play a very strategical and critical role in addressing the mental health challenges as a consequences of the war, provide clinical leadership through assessment, diagnosis and treatment of the trauma related disorder. Capacity building is equally important, involving the training of the primary care providers, community workers, and the mental health professionals. Psychiatrists also contribute to the policy advocacy, promoting the integration of the mental health into the humanitarian and the public health responses. Through search and research and monitoring, we generate evidence to guide effective intervention. Finally, the collaborating with the psychologists, social health workers, nurses, educators, and the community organization is essential for the comprehensive and the holistic approach to combat with this mental illness as a consequence of the war. Psychiatrists are not only clinicians but also leaders, advocates, research, and the collaborators that help in the mental health response to the conflict. Providing mental health care in conflict setting is associated with several challenges. Limited resources often mean inadequate funding, infrastructure, and access to the essential medication. Stigma surrounding mental illness may prevent individuals from seeking help. Many conflictive regions, affected regions also face several shortage of the trained mental health professionals, making more things more vulnerable and making more challenges. So such as additionally clinician frequent encounter ethical dilemmas such as balancing these challenges requiring coordinate effort from government, humanitarian agencies, and mental health professionals. The need for mental health care is greatest in conflict setting. Yet these are often environment where delivering care is most challenging. Looking ahead, innovative approaches will be essential to address the growing mental health needs of conflict-affected population. Digital mental health platform and the telepsychiatry can expand access to the particular needs in the remote area and in the remote resource-limited settings where the individual or the psychiatrist or the other human services are not allowed or cannot be reached. Task sharing models where the trained communities health workers deliver the basic mental health intervention under special intervention under specialist supervision can help bridge workforce shortage. This is also growing emphasis. There is also growing emphasis on developed trauma related healthcare education and social system. NGOs and role of NGOs and the academic institutions and the local authorities play an important role here. So when the war ends, the rebuilding of city begins, but the rebuilding of mind often takes much more time or much longer. As a mental health professional, we must ensure the invisible wounds of conflict not forgotten. So looking ahead, these innovative approaches will be essential address to the growing mental health needs of the conflict affected population. Thank you very much.
Thank you very much, Dr. Vipul Janardan, for finishing the presentation in time. It's a very comprehensive presentation highlighting different aspects of mental health aspects of trauma and war conflict on mental health. And you have also addressed the possible ways to address the mental health impact of war-related trauma. We will be taking questions at the end of all the 4 presentations. Now I invite Professor Renner to introduce the second speaker. Over to you, Professor Renner.
Okay. Yeah, so hello. So I will keep my questions about when to start the interventions to heal and to support. And so the next speaker is Dr. Aliki Eleni Pouli, and I think it's my understanding she's initially from Greece. She's a licensed psychologist, psychotherapist. She's a founder of No Health Without Mental Health, healthblogspot.com. She's an honorary lecturer at the School of Medicine, Cardiff University, UK. She's a member of the British Psychological Society and the Division of Clinical Psychology. She has been trained in psychiatry and is a consultant liaison psychiatrist. She has completed postgraduate courses at the Psychiatric Academy of Massachusetts General Hospital, the University of San Francisco, Case Western University, the National Kabodistan University of Athens, and she completed her postgraduate dissertation on the relationship between certain biomarkers of inflammation and depression. She's very much interested in immunopsychiatry, and she follows all the developments over there. If you could put your video on, then we could see your face as well. And I would ask you to start.
I'm sorry, I've been blocked to start my video. I don't know how.
All right, okay, I just can invite you. Sorry for that. I can
No problem.
invite you. Okay, give me a second. Sorry for that. Asked to start. Okay, so you're asked to start the video if you can do that now.
Okay, now.
Sorry for that.
Thank you, Professor Hen. And it's a great honor for me to be here with you today. Good morning and good afternoon to all of our participants. Well, I heard very, very carefully the Vipul, the Professor Vipul presentation. So I thought that we are running the era of one N, uncertainty, and the 2 I and S, the insecurity and instability era. So today we will talk about the complex trauma and the types of war in the context of global uncertainty. And let me share, we will see what is the war, the trauma, and the global uncertainty, and how these are interrelated. So we will see what is war, different types of war, because we are not in the past that we also, we talked about traditional war and the combat and the battlefield. Now the battlefield will be everywhere. Okay, so we will discuss the different types of war and the trauma war related. The complex trauma and war, and how the types of war and in the context of uncertainty are related to the display of the complex trauma. So we will also address a very, very important dilemma about the global uncertainty context, which is either we adapt or we suffer. So, and finally, we will see the war trauma uncertainty analogy. So let's start. Well, you can see a fruit standing and sees the sun and a beautiful beach at South Pavilion. Well, but what about war and trauma and uncertainty? Are there interconnections? Are they interconnected? So what are interconnections is how the world communicates, power itself, and how interacts. So even we have technological networks, the human relationship, or global systems, we have to understand that all these are interconnected in a constant dialogue. So at this era, we are certainly interconnected. Let me say that because it's an incident that happened a month ago here in Greece. Some fishermen found a sea drone in a cave. They did not know what it's about. So when you just swim and you see there a drone, I mean a war, a weapon war, you start, okay, something that is happening certain miles away comes here also at this Ionian island. So it's very, very important to keep in mind that we are having this instability, insecurity, and of course, uncertainty context. So what is war? We all know that is an organized armed conflict between states, groups, or communities that results, of course, in very, very crucial destruction, loss of life, and of course, social disruption. So we have certain characteristics. We have, of course, violence that is very pronounced. We have many political objectives. This also is observed in human suffering as well as social instability. And of course, we have economic consequences. And now we see that because we know that, as I told before, the interconnection, it's true that economic consequences, the human suffering, the instabilities are also pronounced in countries that they do not have an active war at the moment. So let's see the characteristics of war. We have an organized and prolonged conflict involving armed groups, the state or communities, as we said before. So we have many long-term social consequences, but also we have many short and long-term psychosocial consequences. Well, someone could say, okay, why can we say that war and trauma? Because we know that trauma-informed care and all the studies that came up with trauma had to do with the veterans and during the traditional wars, okay, the World War I, all the World War II. So now we are heading a new perspective on the type of war and how we conceive that. So at the moment, we know that war affects physical safety. Okay, so this is very pronounced and very straightforward. However, we know also that emotional well-being has been affected, family structure, and community functioning. And this, which is very, very important, is that war now, more than ever before, extends far beyond the battlefield. So the place that we have the battles. So the effects of war can last for generations and of course shape entire societies. And don't have in mind only the countries that now are on ongoing wars. We will see that in a few minutes. Well, as we said, we do not have only the traditional war, the interstate war, for instance, the conflict between the sovereign states, okay, which is a bit, we are familiar with that concept, as well as the civil war. And in some countries, the guerrilla war. We have also the proxy wars, and of course, ethnic and religious conflicts. We are all a bit confident about these concepts. We have known, and please say that, okay, we may have terrorism and asymmetric warfare, that also in some countries is something that we can see, and we have some a lot of studies on these type of wars. So the seventh, as you can see, is the hybrid warfare. And of course, as a hybrid, we know that we have a combination of all types of war, or even new types of war. So a combination of a military, cyber, economic, and information tactics. It's not just to say that it's not many experts are talking about the new type of war has to do with attacks on digital infrastructure and have an asymmetric threats. We also see some types of ethnic and sectarian conflicts, and we know some examples of that, the Bosnian War or the Rwandan genocide. So now we see that modern warfare, well, it blurs a lot the line between the military and the civilian targets. So we have an increased psychological harm. And this is the point here about psychological harm. And let's see what is trauma. Well, we know that trauma is a reaction, an emotional reaction. So we have shock, denial as a typical responses to an event that preceded. But let me tell you here that is something that has to do, of course, with the perception of what happened. Okay, so it's very, very important to keep that in mind. So emotional reactions like flashbacks, mood swings, nervousness, mental and physical discomfort, or nightmares are included in the criteria of post-traumatic stress disorder, as we all here know. So we may say that an event like war, an accident, crime, a disaster in a natural context, a physical or emotional abuse, neglect, or experiencing or witnessing violence. And just keep that, because we will see how it's interconnected with uncertainty. The death of a loved one and others can be an event that could be perceived as traumatic. So it's a psychological response. And here comes the perception of the event, the threat, the overwhelm, and the harm. So keep in mind that trauma is not something that happens outside, but what happens inside. We have common reactions like fear, shock, anxiety, and very high levels of emotional distress. And of course, keep in mind that trauma could be acute, chronic, and complex. And now we're going really to our points. So we have a psychological response that overwhelms the capacity, the ability of a person to cope. We may have a combat exposure, a torture, a sexual violence, or a loss of loved ones, and we have these common reactions. Now let's keep something that not everyone responds to trauma the same way. So we have to keep in mind that responses vary according to the support systems available, previous experiences, and aids. So we see here a bit of war-related trauma, and I won't stay here very, very long, but we know that we have key breakdowns of psychosocial repercussions of war, like a breakdown of social trust, forced migration, instability, and then we start with the hard aspects like chronic fear, betrayal trauma, and community fragmentation. We see that these are consequences of a civil war, as we can see here. But we know that the modern forms of warfare has certain characteristics that are not very, very well studied at the moment, because it's something that is ongoing. So we talk today, but there at the moment certain wars that are ongoing. So we are on parallel at the moment. So we have unpredictable attacks. We have a constant uncertainty, and we have terrorism. We have psychological intimidation, and very, very much and high in the agenda is the economic pressure. So let's see the toll that is very, very heavy here. But we have a persistent uncertainty and hypervigilance and collective anxiety. So let's see what is complex trauma. Complex trauma has certain different characteristics of post-traumatic stress disorder. Of course, we refer to this disorder having in mind that we have multiple traumatic events, we have an ongoing exposure on them, and difficulty escaping danger. So the threat is not over. It comes over and over again. And why war causes a complex trauma? Because we have continuous violence, repeated losses, many times ongoing displacement, and of course, prolonged uncertainty. So here we have to know that most victims of the modern wars are civilians rather than military personnel. And we know that. You can see here some of the combat trauma, the types of trauma, and the war has affected specific populations like the combat trauma, the soldiers, or the civilian trauma. And you see the civilian trauma, for instance, that we have non-combatants or soldiers, and we see communities under attack, meaning chronic anxiety, grief, hopelessness, and social withdrawal. These mix of these experiences are very, very crucial to social cohesion. And this is the very, very important thing here. We also see the refugee trauma and how they have them forced migration and the displacement, as well as the developmental one from exposed and experienced by children witnessing violence. And of course, in the context of the children that expose this conflict, we see attachment difficulties, developmental delays, increased risk of mental illness, and of course, many behavioral challenges. And here you can see how complex trauma, and especially the trauma at the refugees population, we have three different stages: the before flight stage, the during flight, and the after arrival on the place that they migrate. So also we have serious consequences like anxiety disorders, depression, and identity challenges. We have very certain studies about the refugee trauma, which are very, very important to countries that are actively engaged in welcoming refugees from war areas. Of course, we have sexual violence, and you see that the impact of sexual violence is on all aspects: physical, psychological, and the social one. And we have also the intergenerational trauma and how this passed one generation through the other. We see some examples of intergenerational trauma, like the Holocaust, the Rwandan genocide. And we have something to say that complex trauma is a bit different from post-traumatic stress disorder. We say that this includes more self-erosion components. And this is not very straightforward. I mean, we develop feeling of worthlessness, shame, and guilt. We face problems controlling emotions. So we have a destabilization of emotions processing. We have a very, very important difficulty to function and to connect with other people. Even we have very high levels of suspiciousness, for instance. And of course, as we see there, we have also relationship problems, like we are not very, it's not very easy for us to maintain friends and partners. So it's more likely to develop complex trauma at a young age when you traumatize from a trusted person, or you have the inability, you are not able to escape trauma. Let me hear you say that we have a large estimation of prevalence of complex trauma. In this place, we have some studies reporting 5 to over 80%. So we have a very wide range here. And we see that we have the key components that we saw before. And of course, the 2023 study from Karadzias and others was very, very precise in assessing the ongoing war in Ukraine, in Ukrainian parents, and found that PTSD was, complex PTSD was 14.6% of the population, and PTSD was at the found on the 26% of the population. So it's very, very important to keep that in mind. We do not have many studies for the complex trauma. It's something that we are hitting now and we are facing. So let's see that uncertainty, what is, and we know all here, but is an affective and cognitive state. So we do not have all the information, we do not have all the pieces of clarifications, and we see that in the context of complex trauma, uncertainty is a primary nervous system trigger, like even in very simple tasks after complex trauma. So we have established an unpredictable and threatening environment, and then the brain learns to process unknown as a threat. So this is something that has to do with perception. It's very, very important to understand this link. So here, uncertainty is a certainty. So we all agree on that. In the here and now, however, we have extreme levels of uncertainty. I think that we are hitting at the present global momentum the highest levels from the history of humanity. So we do not know if we are so equipped to handle psycho-emotional, these type and these levels of uncertainty, because something has happened several miles away, and we may affect it globally. And the global component of uncertainty is really an unknown path for us also mental health professionals, because we are also part of the globe, and we are part of the population, and we are a part of our societies. So we develop, it's very, very important, and we see that clinically every day. We have developed an uncertainty, hypervigilance, and what we can say an uncertainty distress. So many people says that, okay, uncertainty, and the psychosocial one, is like the death of control, or an open door, a wide open door to threat. And this came here as Vipul's presentation of the neurobiology of trauma. We have the survival mode constantly on. We are on helicopter mode, locating danger and threat. You you hear, you're on the train, and you hear a high voice, and you startle, you say, okay, what happened? Is something that happened bad? Well, and this is very, very characteristic of the survival mode that is constantly on wherever we are now. So we have an ongoing activation of the alarm system. And this, of course, has an impact on biochemistry, our body functions, and psycho-emotional functions as well. So many patients report that, okay, it's like I'm in a battlefield. I'm in a constant battlefield. Even we do not have an active war here, for instance. We certainly every day face that. And now it's a high-end psychosocial dilemma. Like, okay, we are in a crucial crossroad here. Adapt, become resilient, or suffer the uncertainty and the complex interconnections and the constant survival mode. Okay, this is the key message here, that psychological adaptation does not exclude any discomfort. Of course, is essential, and is essential to widen our window of uncertainty, how we handle it. So what can we add here as mental health professionals, and our everyday practice could be high levels of self-compassion and existential compassion, because as Professor Vipul told before, we have to raise the sense of belonging. We have to create a strong psychosocial bonds in order to adapt to this ever-changing global uncertainty context. And of course, very, very important is that we need to incorporate in our interventions locus of control, since internalize this locus. We do not have in certain a great now range of control in outside of us. So many activities or daily routines are dependent on our internal locus of control. So it is very important to incorporate that in every intervention, managing either trauma or the constant survival mode about what happened, or that people are constantly alert or anything could go wrong. And it's not the typical population or the typical prevalence that we know we have about the general anxiety disorder or the anxiety disorders. It's something more wide and general population, targeting general population. So here, it's very, very important to keep that in mind, that we have this analogy. So as war evolves, far from the traditional type, and has an hybrid presentation, complex trauma might be escalated because we have various trauma channels. I mean, economic, cyber attack, instability, insecurity. We have many places that perception of threat could lead in. So, of course, we have the prolonged uncertainty, which also keeps the door open to any perception of threat, because uncertainty is associated with threat in our human brain. So let's see that in this bigger picture. So, of course, it affects psychosocial processing and well-being. So we can say that multiple layers of human processing and perception are, in quotation marks, infected by war and high-level uncertainty. And keep in mind that we don't not talk about traditional battle and exposure and violence. Violence could be even extreme uncertainty or the possibility that something will go certainly wrong when I am on the train and going to my work. So it's very, very important to keep in mind that individuals and subjective assessment of threat, the perception in other words, are more important than the severity of objective trauma. This is very, very important to keep in mind, that it's a matter of perception in terms of trauma. So we cannot see, we see that brain is in the middle of the traumatic event. It's not outside, trying to battle, to find a point to escape, to adapt. Is a very, very hard work here. So I am closing this talk with a, I think, great picture of a Greek summer, someone in Seriphos Island, Cyclades. And let's hope that this could raise awareness to us mental health professionals. And of course, thank you. Thank you so much for your attention.
Thank you so much, Dr. Aliki, for your comprehensive presentation. It actually highlighted different aspects of war-related trauma, how the different types of war-related impact is on the mental health. So we will be taking questions at the end of the presentation, all the 4 presentations. Now I will be inviting Dr. Adivya Srivastava for the next presentation. Dr. Adivya Srivastava is a pass out from KMC Mangalore and is a psychiatrist. He is currently working at Homi Bhabha Cancer Hospital, which is a unit of Tata Memorial Hospital, Mumbai. He has several research publications to his name, to his credit. So over to you, Dr. Adivya, for your presentation. Kindly unmute yourself.
Good evening, everyone. Am I audible?
Yes, you are audible.
So, good evening. Today, I will be discussing the wound of conscience, moral injury beyond PTSD toward DSM recognition. This title is intentional. The phrase wound of conscience reflects that the core disturbance is not simply emotional dysregulation, but a disruption of the individual's moral identity. At a broader level, this talk addresses a gap in contemporary psychiatry. While PTSD has been extensively studied and codified, moral injury remains uncodified within DSM-5, highlighting a gap between diagnostic systems and clinical reality. My aim today is not to argue for premature categorization, but to demonstrate that our current frameworks may be insufficient to fully capture war-related psychological suffering. So not all wounds of war are rooted in fear. Some arise from the violation of one's own moral code. This distinction is fundamental. PTSD asks what threatened the individual. Moral injury asks what the individual believes they have done, failed to do, or witnessed that violated their moral framework. This shift from external threat to internal moral conflict represents a different axis of psychopathology, one that psychiatry is still in the process of fully conceptualizing. The objectives of this presentation are fourfold. First, to define moral injury using established literature, particularly the work of Shea and Slits. Second, to differentiate moral injury from PTSD within a DSM-informed framework. Third, to explore emerging neurobiological and cognitive perspectives while remaining cautious about over-interpretation. And finally, to translate this understanding into clinical practice, including assessment, formulation, and management studies. So why this matters now? Modern warfare has evolved significantly. We now see increased use of remote technologies such as drones, complex rules of engagement, and situations where ethical clarity is reduced. These contexts generate experiences where individuals are not necessarily fearful, but morally conflicted. Clinically, this translates into presentations dominated by guilt, shame, and moral dissonance rather than hyperarousal or avoidance. PTSD has been the dominant framework in war psychiatry. It is well-defined, evidence-based, and clinically useful. It focuses on threat processing, fear conditioning, and safety learning. However, its strength is also its limitation. It is primarily a fear-based model. This means that forms of suffering that are not rooted in fear may be under-recognized or misclassified. In clinical settings, many patients do not primarily describe fear. Instead, they describe guilt, shame, anger at themselves, or a sense of having violated deeply held values. These experiences do not align neatly with DSM-5 PTSD criteria. This creates a conceptual gap, one that moral injury attempts to address. So moral injury refers to psychological distress resulting from actions or lack of them which violate one's moral or ethical code. This includes acts of commission, acts of omission, and perceived betrayal by authority. The key element here is not the objective event, but the subjective moral appraisal of that event. This makes moral injury fundamentally different from traditional trauma constructs. Jonathan Shea introduced the concept through his work with Vietnam veterans. He emphasized betrayal by authority in high-stakes situations. This model highlights the importance of trust, leadership, and institutional context. Patients often describe not just personal guilt, but a profound sense of betrayal by systems they relied upon. Litz and colleagues expanded the concept. They propose that moral injury can arise from perpetrating, witnessing, or failing to prevent acts that transgress moral beliefs. This model introduces the idea of cognitive dissonance and moral disintegration. It is particularly useful in understanding individual level processes. Let me draw your attention to two key distinctions here. Shea emphasizes betrayal by authority, which is an external focus. And Litz, on the other hand, emphasizes internal moral transgression and internal focus. In reality, these often coexist. A patient may feel both betrayed by authority and guilty for their own actions. Recognizing both dimensions is important for comprehensive formulations. Clinically, moral injury is categorized by guilt, shame, anger, loss of meaning, and social withdrawal. These are not peripheral features, these are central. Patients often describe persistent moral rumination and difficulty reconciling their actions with their identity. This leads to profound psychological distress. It is important to distinguish guilt and shame. Guilt relates to specific actions, like I did something wrong. Shame, on the other hand, relates to identity. I am wrong. So there is a difference between I did something wrong and I am wrong. In moral injury, shame is often more pervasive and damaging as it affects the individual's sense of self. Moral injury often leads to existential distress. Patients may question their identity, purpose, and values. They may experience loss of meaning, spiritual distress, and values. They may experience loss of meaning, spiritual distress, and alienation. This goes beyond traditional symptom-based models and enters the domain of existential psychiatry. So PTSD versus moral injury, this remains uncodified within DSM-5, highlighting a gap between diagnostic systems and clinical reality. PTSD is a formal diagnosis with defined criteria. Moral injury is not a diagnosis, but a construct that emerges from clinical observation and research. This distinction is important when considering classification and treatment. So core effect in PTSD is fear, and in case of moral injury, it will be guilt or shame. The cognition in PTSD will be on the grounds of I am unsafe. In terms of moral injury, it will be I am morally wrong. Focus in PTSD will be on safety, and in case of moral injury will be on self-repair and the meaning of self. Let me draw your attention to two key distinctions here. PTSD involves hyperarousal, avoidance, and fear-based intrusions. Moral injury involves moral rumination, self-condemnation, and withdrawal driven by shame. These differences have direct implications for clinical management. In case of PTSD, the patient avoids the triggers. In case of moral injury, he gets socially withdrawn. And the effect, as I already discussed, in PTSD will be around fear and anxiety. And in case of moral injury, it will be guilt or shame. Although both involve guilt, the nature of guilt differs. In depression, guilt is often generalized and pervasive. In moral injury, guilt is specific and tied to a moral event. This distinction helps guide treatment decisions. In case of depression, it will be pharmacotherapy, and in case of moral injury, it will be by narrative repair, which will be discussed later. Moral injury is not a DSM diagnosis, therefore, clinical formulation becomes essential. This involves understanding context, moral beliefs, perceived responsibility, and meaning. A purely categorical approach is insufficient. Emerging research suggests involvement of network related to moral cognition, emotional processing, and self-referential thinking. However, evidence is still evolving. We must be careful not to overstate neurobiological findings. At present, these insights are best viewed as supportive rather than definitive. The ventromedial prefrontal cortex plays a key role in moral reasoning and value-based decision-making. Alterations in this region may contribute to persistent moral conflict and maladaptive appraisal. This aligns with the cognitive aspect of moral injury. The limbic system, particularly the amygdala and insula, processes emotional salience. In moral injury, guilt and shame may become highly salient and persistent. This contributes to emotional distress and rumination. The default mode network is involved in self-referential thinking. In moral injury, increased activity may contribute to persistent self-evaluation and rumination. This may explain why patients cannot let go of moral events. Modern warfare introduces unique ethical challenges. Remote operations, drone warfare, and ambiguous rules of engagement create situations where moral clarity is reduced. This increases the likelihood of moral conflict. Consider a 32-year-old drone operator. He reports no fear-based symptoms, but experiences persistent guilt after a strike causing unintended civilian casualties. This immediately raises the question of moral injury. Like, he's a drone operator and he must have been given instructions by the authorities to strike the opposite side. But by mistake, if he strikes a hospital or a school facility, then that results in a moral injury. He will be suffering from moral injury and will be having guilt and shame. So by the help of this case presentation, it will be easy for you to understand what is moral injury. The patient reports self-condemnation, withdrawal, and moral rumination. Importantly, there is no hyperarousal or avoidance. This suggests a primary process different from PTSD. Assessment requires a direct inquiry into the moral beliefs and perceived wrongdoing. We must ask directly, like we can ask leading questions in such cases like, what violated your values? Without this, moral injury may be missed. So, assessment differences. PTSD assessment focuses on threat. Moral injury assessment focuses on moral appraisal. This requires a shift in clinical questioning and perspective. In case of PTSD, we can ask what frightened you. In case of moral injury, the questions will be on the lines of what violated your values. Focus will be on threat, and in case of moral injury, it will be moral appraisal. So moral injury is associated with depression, suicidality, and substance use. Some studies suggest it may be more strongly linked to suicidal ideation than PTSD. This highlights its clinical significance. I repeat, some studies suggest that it may be more strongly linked to suicidal ideation than PTSD. Clinical common errors include labeling all distress as PTSD and ignoring moral conflict. These errors lead to incomplete treatment. Recognizing moral injury improves clinical accuracy. Management focuses on meaning reconstruction, addressing guilt, and restoring identity. This goes beyond symptom reduction. It involves working at the level of meaning and values. So the treatment comparison, PTSD treatment focuses on fear extinction. Moral injury treatment focuses on meaning repair. This difference is critical in selecting interventions. In case of PTSD, we might aim at trauma-focused CBT or EMDR. In case of moral injury, the therapy will be adaptive disclosure. In case of PTSD, the goal is to reduce fear. And in case of moral injury, on the other hand, it will be to restore someone's moral identity. Effective management involves validating moral pain, exploring values, and contextualizing actions. Avoid reducing moral distress to symptom checklists. Engage with the patient's narrative. Adaptive disclosure therapy integrates exposure with meaning making. It specifically addresses guilt and moral conflict. This makes it particularly relevant for moral injury. Narrative approaches help patients reframe experiences and restore coherence. They allow integration of the moral event into a broader life narrative. Compassion-focused therapy this approach targets shame and self-criticism. They help patients develop a more balanced self-view. This is particularly useful in shame-dominant presentations. Moral injury raises important ethical questions. We must consider individual responsibility in the context of systemic constraints. This requires nuanced understanding. Psychiatry may need to expand its framework to incorporate moral dimensions. This does not necessarily mean immediate DSM inclusion, but recognition of conceptual gaps. There is a need for standardized measures, longitudinal studies, and treatment trials. Current evidence is promising but incomplete. Recent literature suggests a spectrum including moral distress, moral trauma, and moral inquiry. This may help refine future classifications. So PTSD does not capture the full spectrum of war-related suffering. Moral injury represents a distinct but overlapping construct. Both must be considered in clinical practice. So if PTSD is the disorder of fear, moral injury is the wound of conscience. Recognizing this distinction allows for more accurate understanding and better patient care. Thank you.
Yeah, thanks a lot. I think give me a second. Thanks so much, and I think we continue like. All right, Sujit is available now, so I think it's now. Yeah, thanks a lot, and I think there are lots of questions about that, and I'm very grateful for this completely new view about things, and I think morals and internal feelings sometimes have been forgotten in psychiatry, and I think that's something I think you brought to the attention. So thanks so very much. And
Thank you.
we just continue then with Vipul Janardan, who should introduce the next speaker. I would like to ask Vipul to just come forward.
Thank you, Dr. Reiner. So this is my immense. Sir, I'm not able to start my video. I think probably you have done it from disabled me from your end.
I think it should be fine.
Hello.
Yeah.
Thank you very much, Dr. Reiner, for giving me immense pleasure to introduce Dr. Parmeshwaran Ramakrishnan. So he has done his graduation and post-graduation from India. Both. Thereafter, he has done his PhD from United States. And he is currently a child and adolescent psychiatry fellow in fellow towards Health Department of Psychiatry, Phoenixville, Drexel University, Philadelphia, United States. He has several awards and scholarship at Harvard, Stanford, GTU, UC Berkeley, and he is clinical director and PI research of Adivya Foundation of the Spirituality and Medicine, New Delhi. He has done many peer review for several psychiatry related journal, and he has more than 50 national and international publication and presentation and the intersection of the religion in spirituality and medicine psychiatry. His area of interest is teaching neuroscience based spirituality and care, and UG. He is actively involved in UG and PG medical education and clinical training and research interest and intersection of the religion, psychiatry, and spirituality. He is also planning to start fellowship program on evidence-based spirituality for integration of the Ayush allopathic medical education system. So these are the few things about him. So I am handing over to Dr. Parmeshwaran Ramakrishnan for his presentation. Thank you so much. Over to you, Dr. Param.
Thank you. Vipul, thank you so much for introducing me so nicely. I also want to thank my other colleagues, Dr. Srivastava and Vipul himself, and Aliki. I heard all of you very keenly, and you made your presentation. Your presentations made my own presentation more easy. So now I'll start with mine. Let me share you my slides. Okay. Hope you're able to see my slides.
Yes.
Okay. I hope it doesn't shrink when I convert it into a presentation mode or slideshow. Okay. It has not shrunk. Thank you so much. So now you can see it in a big way, right? Clearly?
Yes, we can see, Dr. Param.
Okay, thank you. So this is my chosen topic, from Dharma Yuddha, which is holy war, to modern warfare. The physical, psychiatric, and spiritual dimensions of war. My focus is on spirituality, though I have underlined psychiatric also. For me, psychiatry is in itself spiritual. The word psyche, I take it to the roots of the Greek roots, where psyche means soul. So in that way, for me, psychiatry is itself a spiritual specialty within medicine. But I want to add the word spiritual just to make it much more bolder, to highlight the spiritual aspect. The learning objectives is by the end of this presentation, participants will understand the concept of Dharma Yuddha in Indian religious scriptures. I said Indian religious because I have used examples from Hindu scriptures of Ramayana and Mahabharata, but I believe that it applies to every dharma as moral values that can be seen in any other religious tradition. I will illustrate very briefly a few examples of ethical ambiguities within the warfare of, or within in the context of interpersonal battles between individual warriors in the scriptural narratives. And then I will compare with clinical care interactions with my own personal clinical care interactions with patients who have experienced war and suffering from PTSD. And then finally, of course, I will comment on how we can improve the morality of the current warfare and moral strength of our warriors in the current world. Modern warfare are increasingly fought between countries which are based on religious ideologies. So they get into war. At the background, it may be a show of power in the region, or physical power or military might, and or may also be because of economic or financial reasons. But religious, spiritual ideologies, they also imbue the vigor into their you and I versus mentality, which goes behind in wars. Okay, and without going unsaid, it says use of drones, snipers, remote targeting, or use of mass destruction weapons. They have become part of the modern warfare, and how such warfare dehumanizes the very principles for which a dharma, a righteous war, is fought. Many veterans suffer from, at an individual level, many veteran fighters suffer from guilt, shame, moral loss, spiritual crisis, loss of meaning and purpose in their profession. Of course, they're all professionals as warriors, and finally, which all can be clubbed into, of course, many other symptoms to make it a PTSD. Ancient Indian epics, particularly Mahabharata and Ramayana, the war books of those two major epic scriptures, they have explored these issues thousands of years ago, and they still are valid in the current world. So I had an opportunity very early in my training as a clinical chaplain. After finishing my psychiatry, I joined clinical chaplaincy to learn what is an evidence-based approach to spirituality, and what is a spiritual care approach in psychiatry. So I had an opportunity to meet with a war veteran. He was from the Korean War, from the Kuwait War, and he told me how he felt sad and depressed because he was a sniper and he could shoot his enemies, seeing their face and seeing what they're doing from a distance, and they were not aware of his presence at all, and he was able to shoot and kill his enemies. And he told me how he felt sad and depressed because he is shooting people without them being unaware they're in their innocent life situation, sipping a cup of coffee or something like that. And that provoked my interest in studying PTSD through the spiritual care angle, because I was at that point, I was a clinical chaplain, and that was the start of my interest in this area. Bhagavad Gita talks about similar such questions raised by one of the famous warriors of Bhagavad Gita, Arjuna. Okay, he asks, "Why should I kill people? What is the benefit of this war? I don't want I don't want to win such a war where there are several losses of my near and dear ones." So his questions were coming from his moral consciousness. So the first psychological causality of war is often the warrior's soul. So it's for the health of a warrior, it's important for us to understand how the soul or spirit suffers in a war of the fighters. Not only, of course, the major losses of lives of innocent people in a war of the current world, where thousands gets displaced, as Vipul and others have already described. So Dharma Yuddha, or the holy righteous war, stands for justice, honor, restraint, protection, duty, etc. While Dharma or non-righteous wars stand for revenge, hatred, deception, cruelty, exploitation. So the epics of Ramayana and Mahabharata repeatedly demonstrates that the real war often blurs these boundaries of what is good and what is not so good, or holy was not so holy. The Ramayana talks about Rama hitting and killing Vali, hiding through 7 layers of huge tall trees. And then after he downs Wally, he approaches him, he converses with him. There's a big conversation described in Ramayana. Similarly, there's a story of Rama after killing Ravana. Okay, there's a conversation happening between Rama and Ravana, talking about what is good and bad of Ravana, telling Rama the right and wrong things that he has done and about his current fate. Similarly, there are examples of adharma, killing of Bhishma, with keeping Shikhandi, a transgender male, as a shield. And after Bhishma falls down, Arjuna, who had shot Bhima with Shikhandi as a shield, approaches, and everybody else approach Bhishma for pardon and for wisdom. Similar story of killing Drona, one of the great archers, warriors, by disarming him, by lying, saying that your son is killed. Of course, it's half statement. Your son is killed. The name Ashwatthama is killed. Whether it's an elephant which is killed with the name of Ashwatthama, or whether it's a person. So there's a deceit there. And after Drona, the great archer, he drops all his weapons and sits in meditation. His head is chopped off. So there are always moral questions of how to win a war, or how the war is won. Okay, and there are consequences. So moral injury is when person violates their deep moral beliefs, who carries these deep moral beliefs and sacred values and core identities, and then he or she does in the war acts that go against their own beliefs and values, and then they suffer from guilt, shame, and spiritual conflicts. And they suffer. There are consequences also mentioned in the scriptures. There's one similar story of how Arjuna kills Karna, one of his prime opponents, when he's not armed, when he's trying to rescue his wheeled chariot out of the ground. So Krishna justifies in this war, even in the war in Ramayana, Rama justifies his acts of why he killed Vali, because Vali had usurped his brother's kingdom and taken over brother's wife as his own queen. And here Krishna reminds Arjuna how Kauravas were not righteous, up until this war. And so why and how we can kind of bypass the righteous acts within the war itself. So these are extraordinary insights that we get from the epic. Most importantly, what is righteousness in a war? Okay, transitioning to the modern warfare, moral injury has been a key area of research among moral injury among warriors, fighters, military men, is increasingly becoming important in our research, psychiatric research on PTSD. There are several publications. I will list a few of them at the end. Moral injury, Dr. Srivastava had described in depth, and also the neurobiology of it was described earlier by Vipul. Okay, in my case, again coming back to my case study, my veteran with PTSD, he said, "I know it was my duty to kill because I need to eliminate all my enemies, but I still see his face while he was not able to see. I would love to show my strength, military or physical strength as a fighter when I face my opponent face to face, and I want to beat him down. But here I was a sniper, and I was killing him from a distance. I was able to see his face, but he was not, and that was his moral struggle." So that was my patient, 68-year-old war veteran. Okay, here. The epics repeatedly ask what happens to the warrior after the battle ends. And so we are asking questions about what's happening in a military patient, a military war veteran in the current world with PTSD, how to heal his moral or spiritual injuries. Okay, so psychotherapy alone is insufficient. We need to have a moral or spiritual healing happen for these patients. Okay, ancient epics, I spoke about what modern psychiatry offers, but together we understanding all the religious spiritual aspects of the current war. I want to again redirect to the very essence or very reason that is putting so much energy and intentions for religiously inspired wars, the religion itself. Most importantly, the dogmatic approach to religious thinking. A clinical evidence-based exploration of how spiritual principles in scriptures can dissolve the psychological root of modern warfare is important at this point. So here comes my most important part of my presentation. The root of modern conflict is dogmatic religiosity. While geopolitical wars are often motivated by resource, wealth, strategic territory, or pure power seeking, dogmatic religiosity is frequently weaponized to mobilize populations and justify violence. Dogmatism simplifies complex issues into a rigid, non-negotiable binary and absolute us versus them narrative that strips away empathy from the out-group and facilitates mass destruction. Dogmatic versus experiential spirit. Dogmatic mindset is defined clinically as a defensive psychological structure driven by a need for certainty, absolute truth, and group identity. Mechanisms involve absolutism, conditional acceptance of others, severe cognitive rigidity, and the strengthening of the tribal ego. True spiritual principles include rooted in profound self-transcendence, universal compassion, and direct experiential wisdom found within within scriptures of all religious traditions. But we need to reach there to understand what are the empathy and compassionate messages in religious scriptures as such. Empathy and compassion towards everyone, not just one particular group. Mechanisms of such a process requires dissolution of the individual and tribal ego, expansion of empathy, and high cognitive flexibility. Ancient scriptural wisdom comes only when we decode the core messages in each scripture, in the verses of a scripture. When examined beyond literalism, true scriptures teach a profound clinical science of consciousness. By shifting focus from dogmatic belief systems to the actual meditative self-transcending practices prescribed in the scriptures, individuals can dismantle the ego boundaries that feed conflict. Neurobiology of peace, putting in simple terms, mirror neuron mechanisms and all those things, they help in cognitive restructuring. Clinical studies prove that dogmatism is negatively correlated with analytical thinking and active perspective taking. Stress reduction is important. Spiritual contemplation and meditation significantly downregulate the amygdala, reducing biological fear and tribal hostility. Avenue for disarmament, de-escalating religious fundamentalism through clinical spiritual understanding directly undercuts societal tolerance for weapons of mass destruction. The number I gave here is, I'm not sure, I just made it up, 75%. I need to support with better published articles. So disarming the global mind, 75% reduction, bias reduction, can happen with shifting the cognitive rigidity. Clinical data indicates that secular, spiritually integrated therapies that emphasize ego transcendence show massive improvements in empathy and perspective taking for people from the other religious tradition, from nations which are running on different religious theologies, targeting the psychological you versus I or us versus them root mechanism effectively diffuses the aggressive mindset that drives populations to manufacture and utilize weapons of mass destructions. Healing the individual warfare is very important. That's where we learn what is spirituality in the suffering that we see, PTSD that we see among our patients. Mitigating moral injury is important. Combatants often suffer from moral injury, deep psychological distress caused by participating in actions that violate their fundamental moral codes. By moving from dogmatic narratives which crash under the reality of battlefield trauma to true scriptural spirituality focused on healing, forgiveness, and unity of you and I, warriors find a genuine path to post-traumatic growth. This is what we do as a spiritual care providers, as spiritual psychiatrists, when we meet a person with PTSD. Of course, we give various medications also. As a psychotherapeutic process, when we introduce spirituality, these are the things that we do. Provide an empathic listening presence. Final reflection, the deepest wounds of war are not always physical. They may be wounds to consciousness, meaning, and the soul. The Mahabharata and Ramayana scriptures teaches us all about the stuff that I have mentioned. Victory in battle does not guarantee peace within the military personnel who had won the battle. Clinical evidence-based religiosity and spirituality may improve our interreligious differences and mitigate the you versus I mentality in nations separated by religious ideology. These are a bunch of some of the references we have on war and moral injury or religious spiritual. I still have not published my own case study based paper. It's due, and I'll be happy to work with this group to complete my paper and publish it. And thanks to Dr. Rayner for inviting me um, to this talk.
Okay, thanks. Can I just, yeah, thanks so much. And I just would like to say, when we started this idea, I didn't have any idea of this complexity of war. And the other thing is, I would see there's so much to be done. I'm very grateful for Vipul because he just introduced the types of the war and all these impacts of war. I'm also very grateful for Aliki, who just talked about these different types of war and different types of impact. And I think, on the other hand, it's also from Adivya just switching a little bit to the moral impact. And Param, I'm really grateful for yourself to talk about these old scriptures, which just look at completely different moral problems and show off these moral problems. And the other thing is that it's so important that this is something which has been a disaster for the world for years on end. And on the other hand, the research, and this is what psychiatry does, is very limited. And I think what's also is not just your paper, it's I think it would be a book or a very large systematic review what we need to do that. I think Sujit is now chairing the discussion, and there were some discussion questions as well, by myself. And maybe I just start with the first one. You know, when you look at the question I always have is when to start the therapy. So we haven't focused very much on therapy, but you know what we want to do is help people. And at this time, you know, it's a question when to start, where to start therapy. And some people say you should be safe, and some other questions, you know, some people say you can't be safe, so you have to do telemedicine. And I would say, when you look at the differences of war which are currently happening in the world, like Ukraine, where there's some relative security, or in Gaza, where there's absolutely no security whatsoever, and you're not knowing what you do for the next day, and in other pieces where possibly a war is going to start. I don't know what's happening in Cuba, but I think I would think there's so much things to be done, and I'm very grateful for the speakers to make me aware about the complexity of the subject. So yeah, thanks to all of you. And if someone wants to answer the question when to start the therapy, and how to start, and how do you do that with all this complexity, that there's differences between children, adults, warriors, soldiers who are guilty, so, and then other people who are completely out of the area, and they're part of the war. And maybe at the moment we're part of the war because our petrol prices go up. I don't know, that's possibly not the most important part, but so I'm just mentioning this because these are the fringe effects of war, and people are bothered about that. So I don't know, maybe someone can start and say, what is the best time to start therapy?
I think what I feel is like any type of therapy like can be started when suppose the person is approaching you to a psychiatrist or the mental health expert, and during the time of taking the history and clinical history, and the physician or the clinician feels that during that time the patient is in stress, and so it can be started right along with the history. And one more thing is like who have witnessed the war, conflict zones, and war zones and trauma. So debriefing is the usual tool generally used by the mental health experts, but this cannot be used in the case of the child debriefing and other, if it is trauma focused CBT and other therapies, then that can be started as soon as the clinician feel that it is warranted in case of the particular patient or the client.
Very rightly said by sir. Actually, one more thing can be added in this is like the treatment begins from the earliest possible stage, but the nature of intervention changes over time, like whether during or whether the time is during or immediately after trauma, what all interventions can be taken. In first few days to weeks after the war, or if the symptoms persist beyond 1 month or cause significant impairment, then all these three categories, depending on these categories, we can take up the uh, start the treatment. Like during or immediately after the trauma, we can focus on the safety, stabilization, the psychological first aid, meeting basic needs and restoring social support. And then we can reduce the ongoing threat. In case of first few days to weeks, screening for acute stress reactions, sleep disturbances, anxiety, grief, and functional impairment can be done. And if the symptoms persist beyond 1 month or cause significant impairment, we can move on with the trauma-focused treatments such as trauma-focused CBT, EMDR, narrative exposure therapy, and when indicated, pharmacotherapy can also be taken into consideration. An important principle is that safety comes before psychotherapy. Yes.
Okay, thanks a lot. Param.
Yeah, thank you so much. Yes, as Vipul and Adivya have stated, spiritual care, in my idea, spiritual psychiatry or psychiatry itself, focusing on psyche as a soul and spirit, it comes right at the beginning. As soon as the patient walks in with a PTSD and we are interacting, it starts our empathic listening approach to patients, listening to patients' history taking. There itself, the spiritual care starts. But having said that, I believe prevention is very important. We have to develop, expand not from the individual spiritual care understanding of a warrior who is suffering from PTSD. From that, we should step back and step out of the clinical room to become to take part in bringing about policy changes at a national level, international level, at a level of the UNO or WHO, trying to advocate for what is a just war, what is an unjust war, how to change our ideology of dogmatic religious ideology, which drives wars between two nations, which are built on religious ideologies, and then how to mitigate, lessen, and or eliminate weapons of mass destruction. We don't have to kill the entire society, we can limit our killings within a particular battlefield. Kurukshetra, the war of in Mahabharata, before they start the war, they come up with set rules of what are the rules of fighting for this war. So we need to bring about some moral guidelines for the nations which are getting into a war, with starting off a war with the mentality to kill and eliminate others. So I think that's also very important. So this group, I'm thinking, can become a starting point of where we can develop care for individual warriors and also for at a larger level to impact policy making. That's my answer.
Okay. I think Sujit, I think you have chairing the meeting. So is there anything from the I think from the
We can
chat, and I
continue with
think Monica
we
was
can continue with the next question. Actually, this is a question that is put forward by me. So there are some evidences when people are exposed to
I
working
see.
out. War is
I
a
see
form of,
Monica's hand up for some reason.
yeah.
Sir,
There are
I'll come after Sujit, sir.
there are some evidences that war makes people, disaster makes people more prepared. Frequent disaster, rather, I will say, frequent disaster makes people prepared for the more prepared for a disaster. So, like suppose there are regions in the world where the continuous conflict is going on since years together. So, in such scenario, whether this type of war-related trauma or conflict makes people more resilient or make people more vulnerable for psychological morbidities.
Sir, I think let me answer this if all agree. I think, sir, this depends on the personality per se, not to the. We cannot generalize to everybody because we have different personality. We are a psychiatrist. We can understand about this. So, but the frequent traumatic events, no matter whatever the personality is, whether it is antisocial personality or whatever, so it is always like cause a traumatic events, and even the uh, cortisol and other stress hormones will always release because because our brain does not all we are human, we have a cerebrum, we have evolutionary greatness in the sense we have a increase in the cerebral level. So whatever the like human or whatever so we are, so whatever the personality we have, so in any case we the amygdala or hippocampus response always fire or trigger these stress hormones. So we no matter whatever we can we can prepare, that definitely it is a good thing, preparedness about, but we always want to live in the peace as a human. So I think but it people who are more sensitive, they affects very often, and but they are not their temperament is different, so they affects more easier and they are more vulnerable. And suppose the child and women, so though they have like more sensitivity compared to the who have seen the war more often. So this could be the variation in the personality and variation in the person response. Not every person probably respond in a single same way that the other person. This is my view.
Is it Monica now?
Good evening, everyone. I'm Dr. Monica. My question is to Ramakrishna, sir. Sir, I wish to understand what are the similarity which we find between the war which is run for a very long time, that is the Mahabharata, and at that time there was the one called as one of the first counselor, the Krishna, who has helped Pandavas to win that battle for the moral kind of things. And in today's world, what are the similarity between the Mahabharata and the modern war? And uh, at that time, of course, there was some sort of, at least to one group, one help was available, which was regulating their war. And as you said, that it was fought on the moral principles. But now those principles and multiple other things are at stake, and there is a parallel, people which are running a separate war which is on the social media, and somehow it get mitigated very badly, and then people get radicalized. So what is the similarity, and in today's world what we can find to mitigate such situations?
Thank you, Monica. Very good question and an important one. And your question also connects me to the answer that I was going to give to Sujit's questions that with more and more conflicts, we become more thick-skinned or much better prepared for the next war that is coming. I don't think so. That happens. Taking the example of again Mahabharata, they started the war with very nice, very beautiful rules and regulations. But as the war progressed, with each battle, with the morality kept falling down, and as you said rightly, a spiritual leader is important to keep the morals of the group which is trying to fight war against a dharma or righteous war. So a spiritual leader is important to win the war also. Because that spiritual leader keeps the morals upright and the spirit of the fighters up. Okay, so having said that, I'm coming to your question. We need to build an understanding of what is spirituality, what is religiosity, what is religion. I think, coming from a clinical perspective, we can try and understand what is spirituality, an evidence-based approach to spirituality, an evidence-based approach to reading the scripture. All of us have brought up the particular war-raging countries at this point. We have Gaza, where the Palestinians are fighting war against Israelis, and we know one of the major nagging thing is religious ideologies. We know the war between India and Pakistan, where the army chief gives a lecture to the parliament saying that we are fundamentally two different type of people. We cannot be one. If you remember that particular. So if you are fighting war not based on religious principles, which are in the first place not evidence-based religiosity, not evidence-based spiritual, but you keep claiming that my way of doing is right and your way is wrong. So that's what would that would seep in at an individual level, where there's a fighter, when he's facing another person, another warrior, another military personnel from the opposite side, he will perpetrate heinous crimes. We know all the crimes that just not killing the warrior, but dismantling their physical body and doing crap stuff. We know all those things. We cannot say that such acts keep us sane after the war is ended. We will suffer from PTSD, and there's no doubt in that. I have personally interacted with warriors who have come back from various wars. I do feel very proud. I saw one gentleman, one warrior from World War II. So it's very, very rare to meet such people. World War II is when 1930s. So I had a wonderful opportunities of meeting fighters, and I learned personally, at a personal level. I learned as a psychiatrist and learned as a chaplain and spiritual care provider what is spiritual or what is moral injury that warriors face. From whatever we learn at the level of individual lessons, we have to take it upwards to try and build rules and regulations for righteous war. And when we do that, we cannot escape correcting our how to read scriptures.
We have few more questions in the in the chat box. The two questions are from Dr. Adivya Srivastava. Can war trauma even have positive psychological outcomes? In continuation to that, he asked the second question, what the role does technology and telepsychiatry play in war zones? Maybe Aliki can respond to these questions. Can war trauma ever have positive psychological outcomes?
Well, it's a very, very important question here. I think that firstly we have to have in mind that we do not need trauma is not a prerequisite, and war trauma to have a positive psychological outcome. Well, because all the resilience studies state that it's not a prerequisite to be traumatized in order to develop this type of a positive outcome. However, we have some picture that we may develop some of a type of adaptation, but we cannot tell that this could be a positive psychological outcome. We cannot point out that is a positive thing to have, because in this sense we may say that any type of traumatic event can lead to a positive psychological outcome. I think that if we ask all people, even the war trauma affected or any other type of trauma, we can hear saying that, okay, it was not a necessity to be part of this. So this is very important to keep in mind. However, we have some, the development of some different perspectives after surviving a traumatic event. However, it's very, very important to be very, very strict on that. We say that is a positive outcome. We do not have positive outcomes out of war. Someone may say that a provocative, thing could be the high-end bonding between communities. Maybe we have seen that in the history. We have seen that in World War II and some great atrocities that happened there, and some communities, they ended up very, very strong tied. But again, we cannot see that as a positive psychological outcome. It's suffer, and it's something that, as Param said, that we have to have rules and moral rules, and this is very, very important to be on the context. I also think that in this modern warfare, we do not only have moral rules. So, of course, we do not have to think of a positive outcome out of war. Well, as for the second part of the question about the technology and the telepsychiatry, it is very important. We have seen that in very various places like the Middle East, and we know that there could be a very, very hard to enter and have this intervention. So that the telepsychiatry plays a crucial role at this moment. And we can say that if we have the open channels, like we have an access to the internet, to other countries' IPs, it will be helpful to search for and enter an intervention based on technology and distant therapy. However, technology is very, very important here in the terms that we have a great access to multiple sources, and we have to be cultural adaptable in terms of an intervention. So it's very, very important to have in mind that what might be a helpful intervention to a culture or a cultural group might not be so applicable to another. So technology gives us no borders, but we have to be cultural sensitive in any intervention concerning war related interventions like CBT, trauma focused, or narrative history, or EMDR, that we need that physical, of course, physical presence. However, it's very, very important to keep in mind that technology gives us a lot of tools. However, it's very, very important to keep in mind that war is not only taking place in war zones. So in this sense, technology might help a lot to make an holistic intervention in terms of hybrid war, for instance. I hope this might help. So thank you.
Thank you. If I had to piggyback on Dr. Alika, yes, in a way, there's no positive psychological outcomes from war, but in a different way, in a sarcastic way, if I say, yes, there are positive psychological outcomes. That's what is called meaning making. How do we make meaning making of the sad and sad stuff that happens to us, of the trauma? So one of the meaning making or positive outcome is what we are doing now, how to build a better society, how to mitigate trauma. So in that way, but I totally agree with Dr. Alika's long description. I will not again go back. This also answers a couple of other questions that I see in the chat box. Apathy. What about apathy after a war? What about dissociative states? So, if we take another great example that we have in our classical textbooks, a girl, a woman who suffers rape. At some point she gives up and she goes into those dissociative states as a way of dealing her traumatic state of mind, and she may also become apathetic. That doesn't mean that they are solutions. That's not solution, that's not health. So there has to be a different way of looking at healing from war injuries. War injury is not just physical, not just cognitive, behavioral injuries. There are also spiritual injuries. Just as a woman who loses her virginity or gets raped, she is suffering deep spiritual trauma is there. That's the reason why you dissociate. So war or whatever we are working on currently requires a deeper religious spiritual approach. Thank you, Dr. Alika.
Thank you so much, Dr. Parmeshwaran. We have few more. One is from Dr. Christian EU. In frequent cases of clinical overlap, where a patient present with both classic PTSD and moral injury, do you recommend treating fear extinction first before addressing the narrative repair of meaning? Or are there integrated protocols that allow for both approaches to be conducted simultaneously? So, anyone like to respond to this question?
I can take it. Yes, answer is yes. All those things need to happen simultaneously. I have learned from my spiritual care approach to psychiatry, the spiritual empathic listening process happens alongside the diagnostic assessment. We don't have to wait for, as we do with medications, we don't have to wait to arrive at a diagnosis and then start the treatment medication plan and then wait for a few weeks for the benefits to happen. An empathic listening presence it goes beyond CBT, and it happens right at that moment. So that's my answer. Yeah. There may be other
Thank you.
better answers.
So another similar line, there is an interesting question from Deblina Roy. Can anyone talk about one war-related apathy? Can war lead to apathy? And how to manage that? And in continuation to that, she asked another question. What about children who are born and raised during war? What about the mental impact on them? Do they become sensitive to trauma and all types of moral injury? Dr. Adivya, want to take this question? Just in continuation to this, I just want to say that war-related apathy is a very common phenomenon globally. When two countries are at war, to the sympathy, empathy level of the individuals, where the people of the countries are directly affected. And what about the people who are witnessing the war from other countries? They are not directly involved with the war. So just one thing, people, when the war starts, people start talking about war, discussing about war, protesting about war. All those things happen in the initial days. As the war progresses for a longer time, suddenly people become used to the consequences of the war. They don't talk about war. They start living, they start adjusting with the war. They don't feel that empathetic, that concerned about the war. So it's a common phenomenon. People who are, it's more of a type of desensitization. When you are exposed to a traumatic event, a traumatic experience repeatedly, you become desensitized to that event. You don't feel that. It's a type of emotional numbness that people develop. This may happen in the society. So the continuation to the definitely children born raised during the war, they face a lot of consequences. Here I wanted to ask and add one thing, like if you see the sustainable development goals, they are grossly affected by war. Irrespective of the sustainable development goals you see. So war lead to poverty, war lead to a population who are deprived from resources. They are vulnerable to get affected with hunger. War grossly compromises the healthcare facilities and well-being. Definitely countries where war is there continuously happening since years. The education, you cannot imagine about education. Students, the children, they are not going to schools. They are in the refugee camps. Schools are destroyed. And you cannot imagine about gender equality, sanitation, clean water, affordable energy. All those things are grossly affected. So continuous war, your target for attaining the sustainable development goals are gradually become delayed. You may not attain many of these attainable goals that you are targeting years back before the war. So finally, it is affecting the economy, growth, and development of the society. So whoever is children which going to be born and to be raised during the war period, they are likely to experience all these adverse situations in the society. And the impact of this adverse situation is likely to affect their mental well-being, physical well-being as well. Like just you can think of the World War II after the Hiroshima Nagasaki attack. After that attack, a lot of things happened in the children who are born to the mothers who were pregnant during that time. They developed a lot of congenital diseases, a lot of genetic diseases. They developed, majority of these children are crippled. So the biological warfare and atomic warfare, they have their own consequences. We cannot escape from that. And children who are in the developing phase, they are likely to get affected by these things.
Okay, can I just, I think Deblina wanted to ask a question. Thanks a lot for this very important contribution, Sujit. Can I ask Deblina to ask their
So
question?
my question has been kindly answered by Sujit sir. My question was related to children who are being born in the war situations and raised. So basically the education, their development, and I don't know, I kind of feel, do they feel the sympathy, empathy, and do they become sensitive? Because the kind of experiences that they have. So this is a question to all the great speakers that we have today. Like, how do we heal something where the child has no memory of actually having something meaningful in the beginning?
Okay. Okay. I'll give it back to Sujit. Is there any other questions? Because I haven't followed this properly. Sujit, are you there?
Any further questions from the audience? You can ask directly to the speakers, or you can put the questions in the chat box.
Yeah, sir, I'll just add up to your what you have already given to Devlina's question. So the studies which we have done, because I was studying about radicalization for a long time now, and the research studies in this area are very, very poor actually, because they come to the high conflict area, and somehow those population falls under the security forces. So even if we want to do some psychological kind of study, that is very difficult. So to comment on whether what kind of impact those children faced, that is slightly difficult. And the people from security forces, legal people, only those people are allowed to do the studies. Maybe in India, DRDO. So, but whatever so far has been accumulated or summarized by the people, apparently one point which sir already told, that they become desensitized to the violence. So repeated exposure kind of make them numb, and so the violence, death, fear, that's seems normal to them. Another one is that that emotional numbing which happened because it is a repetitive exposure of those things. So there are multiple documentary which is made across India toward Jammu Kashmir region, then Himachal Kinnaur region, which is along with the China border, and then toward this northeast side, the Assam part and the. So there the children, they themselves become alert. So for me, who's sitting in the central of India, I might have fear that what will happen next. But if you go and interact with those children, they will be, very normal compared to me who's sitting here, because we have that perceived fear. But those people have faced it, and now, the kind of conditioning which has happened, that have made them, we can say, desensitized, or I think it is kind of normal to them. Another one is, it is the nature law that people learn to survive the conditions. Our conditions are different. We are learning as per them. Their conditions are difficult, harsh, and they are learning to adapt according to those situation. So naturally they become very much alert compared to a normal person who's staying away from the conflict area, emotionally detached, as they cannot invest themselves too much into that, and they become mature comparatively too early. Of course, with the some coping mechanism, whether faulty or good mechanism, but that kind of instability will be there. All those people, some of them on the laterhood of their life, they want the sort of psychological mobility. So this is what the data says. Yeah, thank you.
Thank you, Dr.
Thank you, Monica, for your inputs.
If there is no more, is there any more questions, or if there is no other questions, then we can think of closing the sessions now.
I think
Professor Renner, you want to make any final comments?
Yeah, I would like to say thank you and very much. I appreciate all these variations. And I must admit, when we set this up, I never thought about this width of knowledge and the width of sad problems in the area. And I'm 100% sure this needs more research and much more knowledge about psychiatry. And I hope we can contribute to that. So I'm very grateful. And yeah, if you want to join the Global Psychiatric Association, which you might or might not have done, and yeah, help and contribute. And the next big action is our annual conference from the 11th to the 13th of September. And Sujit, last word from you. I say thank you to everybody and bye.
Dr. Monica will be giving the last vote of thanks for this presentation, for this symposium. Over to you, Dr. Monica.
First of all, I want to thank everyone present here. I'm very much thankful on behalf of GPA members, our association, to all the speakers for giving your valuable time and giving such wonderful insight to this topic. Initially, we started this topic with just one topic, that it is here on the platform and we want to understand about this. But I think from understanding all the question answers and through the presentation, what we have learned today, that it's not just a small area for one simple symposium or a conference. It can be developed further with the research and along with multiple conferences and discussion along. So in conclusion, I just want to say that war is not a new phenomenon. From ancient epics such as Mahabharata, Ramayana, then moving to World War I, World War II, and present-day conflicts, which is ongoing and, in the multiple areas they are happening. Humanity has witnessed war across different eras and culture, and nowadays we can say religion-based wars as well. Although the nature, the weapon, and the reason for the war have changed over time, one aspect have remained constant, that is the psychological and emotional impact on the individuals and societies. So beyond physical destruction, war leaves behind moral dilemma, grief, fear, loss, and trauma. As we discuss warfare across time, it is equally important to understand the psychological consequences that comes along with it, that often continue long after the war has ended. And many people cannot even come out of those trauma. So going ahead, what we have to do, that involve multiple training, capacity building, and training our basic graduates. So whoever is there on the border, along with multiple people who are there, they can sensitize the people. So training in this area is much more needed, as per my awareness today. Right now, we are not exposed to such situation. Right now, neither of the training has this kind of curriculum where we are exposed that how, of course, there is a military psychology, military psychiatry, everything is there. But we are never, exposed to such kind of people. We are never exposed to such kind of issues. So if we want to learn what is the actual trauma, what is the actual injury, because I come from such family where people have gone through this, and we come from such family where our father was on the border and we were always scared what will happen next. So that constant fear sometime change into anxiety disorder in the laterhood, and then people doesn't want to go again in the army or to such things. So one is of course the veteran, and then comes to the people who are there on the living across those area. So I think training in this area will be much more essential. Thank you very much to all the speaker and the audience.
Okay, thanks a lot, and I finish now. Bye-bye.
Bye-bye.
Thank you. Good night.
Good night. Thank you.